Good. Thank you for telling us. And here we go. Good morning, everyone. We're going to be talking today about medical and mental health care for adults and youth with autism spectrum. I've got a long lead into this discussion, but it's an interesting topic. And the good news is there's a lot to be done. And the bad news also is there's a lot to be done. And that's kind of a theme this morning in terms of what we do and don't know and what we can and can't do. And you'll see I've got my little GIF files here of a Yale Bulldog and a Southern Owl just to show my allegiances over the years. My conflicts of interest, I've had some grants over the years, some books, and I edited the Journal of Autism for many years. And before we start, and I don't take my little GIF of the boy begging with a begging bowl, but just as a reminder that these talks we offer are free for anyone who wants to participate. They do cost us, not for our own internal people. I do this for free, as do other Southern folks, but our outside folks, we pay a small stipend to. And if you have any wish to make a small donation, please don't hold yourself back. These donations help because this does cost us something, and we have to really make our money to be able to continue to give these talks. And we're delighted to do it. But please think about making a small donation. So let me say a little bit about my personal background on this because it's actually quite relevant to what we know in terms of the field. I got to Yale in 1980 as a child psychiatry fellow. And I think within the first week, I was working with a man named Donald Cohen, who's interested in autism, which was the big reason I came to Yale. And the first week I was there, he connected me up with Rosenberg House at Ben Haven, which is the one house at Ben Haven, which is both a school and residential center, the one house for adults. And these were the people that they had as their earliest students who they'd made a lifetime commitment for. And they kind of realized, oh my gosh, if we keep making this lifetime commitment, we're going to be turned into an home. So they had this one house that was only for adults. And I got invited to dinner, which was a real, very interesting experience because people cooked and they cleaned up. And it was all teaching, and it was all very much, the people did it themselves. And this was a fairly impaired population. And this was a really extremely high quality program, which it remains to this very day. And I only stopped working with them about 6 months or so ago before I retired from Yale. But it was nice because this was my introduction to quality care for adults with autism, but adults who needed a lot of residential care. And subsequently, I've supervised a lot of fellows in child psychiatry. I've worked with medical professionals. I can tell you some sad, funny stories about that at times. And we just have this book, which is about to come out in December, which is the second edition of a book, Adolescents and Adults with Autism. This very much follows up on the original book, which was by Eric Schopler and Gary Mesabov, published some decades ago now, also by Springer. Which has really been one of the mainstays of information on this topic. So I want to, again, emphasize that today I'm focusing on adults. I want to say a little bit about background concepts and diagnostic issues, but especially about comorbidity, because that becomes a real problem or issue for adults. Talk a little bit about treatment approaches, gaps in coverage, and some of the things we might think about for new models of care, as well as some of our specific needs and some of the places where information is lacking. And to think a little bit, and maybe we can talk more about this also in the question period, new models for training and care, which I think both of those are very much intertwined as we think about new approaches for adults with autism. So autism was not officially recognized in this country until 1980 in DSM-3. Once it was recognized, and for adults, it was called residual infantile autism. And for the adults who had it, it wasn't too residual. But interest started to increase. There started to be more and more research. By the 1990s, this had really started to increase. And subsequently, there's literally been a tsunami of work, much of it focused on treatment, and especially on evidence-based treatment. The report from the National Research Council, some 20 years ago, continues to be widely cited as a landmark in the field. But what counted then as evidence-based treatment no longer would do so. Back at that point in time, it was having one published paper, and now you're going to have multiple papers in multiple locations and or a double-blind research, randomized control research study, and or a meta-analysis. So things have gotten much more sophisticated, which is good. The diagnostic issues, just to very quickly summarize, we have both categorical and dimensional approaches to diagnosis. Just a word of caution on both. The dimensional approaches, things like the ADOS and the ADI, the ADOS in particular, all these things that started out as assessments you did with a child to look at autism, they really almost all, and Kathy Lord has published to say this, started out with school-age young boys with mild to borderline intellectual disability. And so that's where they came from. So it's not necessarily a surprise that they wouldn't work so well with other populations, meaning older people or girls, women. And that seems to be the case, and that's a whole discussion in and of itself. The categorical approaches have their own issues, which we'll talk about in just a second. The DSM-3 I mentioned, which was great in terms of adding infantile autism, was a problem, and that its approach to dealing with adults with autism was to say they had residual autism, and sadly their autism usually was not so residual. Over time, there were some subsequent changes made in DSM-3R and then DSM-4. DSM-4 was around for a very long time. With DSM-4, there were over 2,000 ways to get a diagnosis of autistic disorder. With DSM-5, as you're going to hear in just a second, we've had some problems. DSM-5 was really developed partly, well, actually for the most part, by using instruments like the ADOS and the ADI and coming up with new approaches. This has a slight aspect of the dog chasing its tail in some ways, and we can talk about some of the limitations about that. But now there are only 12 ways using the current system to get a diagnosis of autism. And as you'll see in a second, adults especially pay a price for that. So there's a fair amount of published data now to show how well DSM-5 works. The problem is that, and this is a published study that Jamie Cartland and Brian Reichow and I did some years ago, that with DSM-5, almost all the cases that used to have Asperger's and NOS, both of which got lost in DSM-5, they lose a diagnostic label unless they had a well-established label, in which case they keep it, but you can't get new ones. And even of the kids with the people with autism, about 25% of the higher IQ cases lose their label. And this is a problem in this country. The labels are important insofar only as they are needed for research and or diagnostic access to services. And again, this is a tension. And it seems like especially higher functioning adults, the higher cognitively functioning adults, and those at late diagnosis are at a special risk because they can't get a label. They no longer qualify for it. There are some problems with diagnosis in adults, and I have some references here. And just in case, I'll remind you that at the very end of this talk, I'll have a whole set of slides with references, and this will all be put up online. So if there aren't references listed, you'll find a lot of them in the 4 or 5 slides I have of references at the end. We know that there's probably a tendency to underdiagnose women and probably certain other groups. There's some issues around minority misdiagnosis and underdiagnosis, but especially it seems there may be gender issues. There also may be some important cultural issues. What's very interesting, my good friend and former trainee, Susan White, did a nice study some years ago down at Virginia Tech. She got burdened with the task of teaching, I think it was Psych 101. And so she decided to turn that into something she could use. And so in the first day of class, she asked the students to fill out 2 questionnaires. One was a quick and dirty categorical screener for autism, and the other was a longer, more detailed diagnostic study for autism. And she found between 5 and 13 of her students had undiagnosed ASD, and she followed up and she discovered that indeed that was the case. They had never had a diagnosis of ASD. They didn't need a diagnosis of ASD, but they qualified. And so that just is a reminder that people do slip through the cracks. And again, if they don't need the label, that's perfectly fine, except insofar as if later in life they need the label. For example, going to college and discovering all of a sudden they need a label. So conversely, you do also see reports, and Debbie Fine has talked about this extensively, of some students as children who qualify for services under any of the DSMs, but seem to quote unquote grow out of it over time. This is what she calls optimal outcome. These are students who no longer technically qualify. Now, I should point out that these students almost invariably continue to have troubles of some kind or t'other. So again, keep in mind that we see all kinds of very interesting shifts back and forth with adults and with the more able, but also sometimes with the people who have more difficulty. Comorbidity, and I'll explain what Mark Twain is doing here in just a second. Comorbidity is having more than one problem. There's different approaches to this. The DSM, or the American system, has one approach. It encourages multiple diagnoses. The International Classification of Diseases actually tends to encourage a single diagnosis. So they have things, for example, ADHD with conduct disorder. That's a diagnostic label. So you've conflated the two things so that you can pull those out as a separate category. There's not a right or wrong or this, it's a complicated issue. One of the problems also is when you start to get multiple labels, one of them sometimes overshadows the others. And for school purposes, we know that often when a child has multiple potential labels, autism is often used because it gets the child the most services. The available data are quite limited. There are case reports, which is where Mark Twain comes in. In just a second, I'll tell you what the problem is with Mark. Clinical series and representative samples. Most of the data comes from case reports. Mark Twain, who was a famous newspaper reporter before he became a famous author, talked about how there were three kinds of stories. There were stories that are true, there are stories that are false, and there are stories that appear in the newspapers. That's also true with case reports. Case reports are not very helpful when it comes to comorbidity, hearing a case of autism associated with Down syndrome. That may be very interesting. It may be published several times. You're not going to hear about a case of autism not associated with Down syndrome. So there's a bias there. And that's meant that, for example, when I took over as the editor of Journal of Autism, I basically said, we're not going to publish case reports anymore. We will occasionally publish a case report as a letter to the editor, only when it's extremely interesting. And that's, again, one of the problems with comorbidity. We don't have great data. Had Mrs. Clinton won the election, one of the things she was going to do with adults with autism was do a national study of adults to find out how many there were. And one of my suggestions to her, which she actually incorporated in her final proposal, was to say that we would also look at their needs. She did not win, of course, and that study never got done. And it still hasn't gotten done. And that's an important thing to realize, is that we still really don't know enough about how many people are out there and what their needs are. So what are the mental health conditions that are increased in adults? There's pretty strong evidence for anxiety, depression, and suicidality being increased, especially starting in adolescence. There's moderate evidence for gender issues, gender dysphoria often starting in adolescence, and sometimes substance abuse issues. There's much weaker evidence for things like eating disorders, OCD, Tourette's syndrome, and bipolar. The strongest evidence comes from these larger case series and these more representative studies. I should note that attention problems, which sometimes do qualify for a child to get attention deficit disorders and diagnosis, attention problems can persist. And I also should note that things are often interrelated. One of the secrets of this talk, I'm going to tell you in advance, is to do well as an adult with autism, you ought to have a job. If you don't have a job, you get depressed. That leads to overeating and obesity. That leads to medical complications. So all these things are very much interrelated. And a person who's helping to care for an adult with ASD needs to be aware of that. We've talked about the limitations of available data. One of the problems here is we really need better data. The best data we have probably come from some of the drug studies in the higher functioning, meaning the more cognitively able adults. So we have probably the best data for adults around the drug studies. We often need multi-site studies, but those are very much lacking, and we often have very small samples. So as you'll see later on, we have pretty comparatively less work on adults. Much of what we know, with the exception of psychopharmacology, comes about by generalizing results from studies of children and adolescents, and as we know, that has its own sets of limitations. What medical disorders are increased in adults? And again, the major caveat here is we don't really know very well. Probably epilepsy. Epilepsy is increased in adolescents and adults. One of my funny little stories of epilepsy is one of the people I've been taking care of for years and years and years was at the having a summer vacation with her friends, and this was a fairly impaired lady with autism, and she, for the first time, had a seizure. And they took her to the emergency room at the local university hospital. And I got a call from the emergency room and the neurologist on call and the ER doctor. And we agreed that she was not driving heavy machinery, and the thing to do was just to watch and not to necessarily medicate unless it came back, and blah, blah, blah. And so then the ER doctor said, well, I'll wait till she can have a conversation with me and then I'll let her go. And I paused and I said, I've been taking care of this lady for 30 years and she's never had a conversation with me. So good luck with that. But that's kind of what you're up against sometimes. People who are well-meaning but don't know enough about autism. We also know there's some suggestion of increased risk for Parkinson's. This is somewhat even less sure than the epilepsy. It's one paper, but it's worth noting that there is this report of increased risk. Probably the most common things we see are the effects of drug side effects and polypharmacy. We'll talk more about polypharmacy in a minute. Obesity, lack of exercise, and risk for all kinds of medical problems clearly is a major issue, and sleep problems, which continue to be a problem that's first observed in children. Psychological treatments, interestingly enough, of course, psychotherapy got a very bad rep in autism for the early approaches of Bettelheim and others to cure autism through psychotherapy. But interestingly enough, psychotherapy has made a bit of a comeback. And here's a book, again, by my good friend Susan White on CBT for children, adolescents, and high-functioning autism spectrum disorders. This work has come back. It's a very nice approach. CBT has many things in its favor in terms of working with adults. It's usually time limited. It's very focused. You have homework. There's things to do. It's a very good approach, and it can be easily modified for the individual. And it's important to realize that this is out there, and it's a nice tool to have when now we're dealing with adults with autism who need some help around especially issues of anxiety and depression. Outcome is a very interesting discussion. We're only going to hit on it very briefly, but on outcomes, substantially outcome has improved, probably because of increased awareness leading to earlier diagnosis and better outcome. We have better treatments. We also have now some potential biomarkers, EEG and MRI changes in response to treatment, which is very interesting. I should note that we still have challenges in terms of screening. That's a whole nother talk in and of itself. But we're doing a better job, and outcome reflects that. At the same time, we still have a group of probably about 30% or so of adults who continue to need high levels of adult supervision and support. And it's important not to forget about them when we talk about some of the higher functioning people. This slide just summarize, and I'm emphasizing I'm cherry picking here. These are data from Pat Hallen back in 2005. It's probably about time to add a third little figure to this slide, but you can see the first outcome studies. Good outcome, which meant you were totally independent, maybe was around 5%. This is the studies from 56 to 74. Fair outcome, which meant semi-independent, so you were living close to your parents, and they or your siblings were very much involved in your care. The number gets a little higher, but about 2/3 of people were in residential care. But then give it 15 years, and the 15 years is intentionally selected because I'm letting the effects of Public Law 94-142 hit in this country. So now we're starting to see the effects of earlier diagnosis and intervention. And look at the outcome. We've got up to 25% or so. And now if you see, look at the fair outcome, that's also increased. So that all of a sudden, between good and fair outcome, we're probably getting over 50% of the cases. And as I say right now, the best guess is that number would be about 70%, with about 30% needing longer-term residential care. Those are remarkably good numbers. Again, we haven't succeeded with everybody, but we're doing much better, which is good. Now, this brings us to one of the very interesting questions, and anybody who's taken one of my lecture classes at Southern knows the answer to this question. Where's the best place to live in the world if you have autism? Take 1 second to make your prediction. Well, I have a sip of my coffee. And the answer, Utah. That's if you believe the published data. This is from Megan Farley and her colleagues back in 2009. Almost 50% of the people in her study were independent. Another 33% were semi-independent. So that's a big number. About 66% were employed, 20% had long-term relationships. And you might ask yourself, what's unique about Utah? There are many things, but including the fact that if you're in the Church of Latter-day Saints in Utah, if you have a child with autism and that child is giving you grief, you can pick up the phone and call someone in the church, and someone will come and take that child off your hands for a little while. There's relief, there's support networks, people are nice, there's a network of small communities, there's an emphasis on inclusion. You can make a case for why this would be the case, but to date, the best data have come out of Utah in terms of outcome. So the good news about outcome, it's clearly improved, and that's not just changed to diagnostic practice, but seems to be a real change. The rates of intellectual disability and the total inability to communicate verbally have markedly decreased. When I was first in the field, about 90% of people were intellectually disabled, and over half never talked or only talked very, very rarely. We have more and more students going on to college or trade school and entering the workforce, and we have more adults seeking friendship and romantic relationships. On the other hand, the outcome studies have some less good news. As I mentioned, about 30% of people still need significant level of support. At the ages of 18 or up to 21, 22, depending on how far your high school is willing to support you, once they cut that off, you literally fall off the cliff in most states if you don't have some other entitlement like intellectual disability. So that's the bad news. We get people to be in much better shape, and then we pull the supports, and then literally they fall off the cliff. Even with a college degree, only about 50% of people who seek work get it, and those who get it are paid more like high school graduates. This is Calvin Solomon did a wonderful review paper, which is in the references, as you can see. This is really bad news. We get these people into college, we get them out of college, but only half of them who seek work get it. This is in contrast to every other disability. Any other disability, people are employed at rates similar to the general population, not so in autism, and that's really a major, major problem. I should also point out here that we have very limited data on relationships and children. As far as I'm aware, we don't have any published data that I know of at the moment on the children of people with well-diagnosed autism. The handful of people I have met have had children, sometimes with autism, but we really don't know. One of the good news about colleges is that colleges came from monasteries. Monasteries were very structured. They were ordered, they were predictable, they used a lot of routines and schedules. All these are things that play into strengths. On the other hand, to some extent, you can also, minimize social interaction. You can hole up in your room or a cubby in the library and do your work. So it has a lot of potentially going for it. The less good news, well, there's some challenges. All of a sudden, instead of having 4 or 5 hours a day of classes in high school, in college, we might have 4 or 5 classes a week. In high school, you've got frequent tests and homework to force you to keep up. In college, you have the occasional exam and or pop quiz. In high school, the teachers provide a lot of content on the textbook. On the other hand, in college, there's expectations for the student learning on their own. Class size changes dramatically from 20, 25, 30 max up to several hundred students in the class. In high school, you usually have one building for 4 years, and in college, you have many buildings for 4 years. So there are a lot of challenges, and we know that more and more students are going to college, and we have some programs that are now developing to help students learn about going to colleges. We know there are a number of academic challenges. Some of these we can help with. Some of these they need a lot of support on. One of the things that's most challenging are judicial affairs issues. Often our students are interested in having relationships. They are very one-sided and awkward in their approaches to other people. This may be taken very unintentionally as being inappropriate sexual approaches. And this is the kind of things that gets kids kicked out of college very quickly. And it's a sad commentary on life that this happens often, that our students make inappropriate advances, not realizing that they're moving too quickly and they're out of their college program. Other challenges, executive function. This is the whole set of things are involved in forward planning and multitasking. This is kind of not a surprise in some sense when you think about social interaction starting in infancy. Social interaction involves a lot of executive function. What's your parent looking at? What are they thinking about? What are they doing? What are you thinking about? What are you doing? What do you want? What do they want? And how are you going to do this? And how are you going to get that nice toy over there? And blah, blah, blah. And it's all very, very fast paced. And you're paying attention to a lot of different sources of information. For many of our kids, they pay attention to one focus of information. They have trouble integrating other systems, and they have trouble changing when the data go against them, that they're not being very effective. So we have a need to think about this, and I've come to appreciate this is one of the things that really also predicts adult outcome is executive function. As you heard at the beginning of the talk today, we were plugging our traffic stops next week in Fairfield County at Sacred Heart, and driving is one of those things. It has a lot of executive function aspects. People with autism can drive, and we want to help them have good interactions with police and use the Connecticut Blue Envelope program. But it's a challenge, and it's one thing that we really need to help them work on. The dating and sexuality, again, another important set of challenges, and mental health issues. The supports are variable. Most colleges, they kind of know ADHD, so they know, okay, we'll give extra time on tests. Okay, we'll give a tutor. That's okay. Well, they're not so aware of social supports. Things like having a peer mentor, facilitating long-term periodic counseling, having mental health supports, what you can do in terms of getting permission from the student to talk to their parents when things seem to be going south. So again, planning in advance can be helpful. I encourage students, if they've selected on a college, to go spend time learning the place and the system. Our colleagues up in Canada, in Toronto, for example, at the University of Toronto, if you have a disability of some kind, which they all know, it's not a secret, unlike here in the US, you're invited to campus a couple of weeks early to get to know the campus, get your ID, find your dorm, do all that kind of stuff. And we don't do that, and it's unfortunate. I do want to say a word on high functioning. People use these terms in somewhat different ways. Some people, and again, I used to myself talk about this, as I think most people did, thinking about outcome, we talked about nonverbal IQ and spoken language at age 5. Well, we've come to realize that IQ and language are not the only predictors. Executive function is one, adaptive functioning, street smarts is another, and the other one is motivation. And the scene here is from Star Wars when Luke points out to his Uncle Owen that the R2 unit has a bad motivator. If you don't have the motivation, you have real trouble. If you do have motivation, that's something to really work with. And if you're going to be taking on somebody doing therapy or counseling, if they've got motivation, that's a very positive sign. If they don't have the motivation, that's not such a good sign. And again, we sometimes conflate all these things in terms of cognitively higher functioning. I'm going to show you a slide in a second to disabuse you that cognitive necessarily means higher functioning. And so here I am. Here's a man with an IQ of 140. He's a math genius. He solves equations in his head. He has a favorite kind of equation, Diophantine equations. And he is working on a problem here. And I don't know if you can see at the top where he starts. And here is his bottom answer, 0 equals 0. Let me give you just a very quick second to see if you can think what this is all about. He is asking the question, can I have a girlfriend? Now, those of you who've had long-term relationships or been married realize this ain't the way you go about asking that question. But he's using what he knows. And you can see that even though he's a very bright man, he is extremely impaired. So would you say he's high functioning? Well, I probably wouldn't myself. He cannot walk into McDonald's and get a cheeseburger and change. He's just too overwhelmed. That's not high functioning, but he's still cognitively high functioning. So we need to think through that whole set of issues around nomenclature, and it's still emerging. Low functioning autism. We do have 30% or so who are less responsive to treatment. Again, the terminology varies. My good friend Kathy Lord has talked about profound autism as a term that has its own set of baggage. But we do have this set of folks, and we've known this for some decades now, who, despite pretty good treatments, don't seem to make the kind of changes we would like to see. And this is a population that needs to be studied in its own right to see if we can understand more about what that's about, whether it's in terms of increased genetic risk, whether there's some additional burdens in terms of learning, but we know really very little about what it is that in this group makes them so difficult to provide for. Legal entitlements and supports gets complicated. Students in high school often have an IEP, which means they have the IDEA as a legal framework. And that really limits what schools can and can't do, it puts a lot of constraints on schools. As students graduate, all of a sudden that support disappears. We have ABA supports for adults in college or in the workplace, and the ADA supports are things like having support in the workplace, having support around a disability. We know that there's a 7-fold increased risk for legal involvement of all kinds in adults with autism. We know that driving can be a major vocational problem. Having the ability to drive really increases your possibilities of getting a job, but driving is an issue. And having a job is probably the major determinant of adult life satisfaction. Having something that you can do that you feel worthwhile about on a daily basis is a really important source of feeling better about yourself. We also know that adverse childhood experiences, ACEs as they're called, in regular children and typically developing children, having multiple ones of these has a real cascading effect on adult health and mental health problems. Interestingly enough, this is this big study that was done actually out in the Kaiser network out in California. We know that in autism, all kinds of things, and again, the literature on this topic is small, but we know that those kinds of things that can add to adverse childhood events, bullying, between 40 and 70% of children with autism are bullied, poverty, low income, parental stress, mental health problems in the child and or in the parents. All of these things are things that can be adverse childhood experiences that could then presumably also play out long-term in terms of both health and mental health sequelae in the child. Services for autism and for adults in the US, it's a crazy quilt, as I hope I've put over there for anybody who's a quilter who can appreciate. People have tried a meta-analysis. It's a mess. It's the short summary because there's such variation. There's variation from state to state. There's variation in terms of programs. There's all kinds of obstacles. It's similar in many ways to Europe in many respects. The obstacles have to do with eligibility. Services are quite varied. It ranges from some kind of simple supports, weekly counseling, group living, Medicaid, job help, social skills, individual therapy, et cetera, et cetera. It's just everywhere out there. If you look at the kinds of programs that are available for adults, we know, for example, there's around, I think the last time I counted, there was around 80 programs that were transitional programs to help people, high school students with adults, go on to college or go to trade school. With very few exceptions, the one exception being Susan White and now at the University of Alabama, who's published 2 papers on her support program. The division Teach People have a support program they have not yet published on, but I know they do it. And it looks like a very good program, but most of these programs, which are very expensive, unfortunately, they don't have a lot of data to show how effective they were. I'm not saying you shouldn't do them, but I am saying that the data are lacking. And these are costly programs, and people probably already know the cost for residential care for an adult, one of that 30% of people who needs a lot in terms of residential supports, that's around $250,000 a year baseline. So these are expensive programs. It's expensive not to have programs. And so it would be nice to sort of think we had a rational system, but we don't. And it's even worse for adults than it is for children, if it's hard to believe that. We need greater flexibility. You can run into very odd problems with the state. I have a good friend who has a brother who's pretty impaired. He has a condo for his brother. as somebody who stays the night. The brother has a day job. He offered the state to use this condo as a group home. The state said that'd be perfectly fine, except his brother has to then go on the waiting list for a placement. And that's the funny kind of thing you run into. Or I was just literally yesterday looking at a new facility that's coming online here in Martha's Vineyard, where I'm actually talking from this morning. And the state was saying, well, we'll have to place people from all over the state here. And the lady was saying, no, we want people from the vineyard who have family, who have supports here. And that's the kind of thing that's going to sometimes cause discussions. We need to have parent and family involved. It's important for parents to realize that siblings need to be involved. Parents can't just assume things. They can't just assume a sibling is going to take over and be involved. It needs to be discussed. We also need some new policies to replace some of the older models. And we need to, importantly, to talk to people about what they want. Pat Hallen has talked about this in some of her recent studies of outcome. And what people will tell you is they want things like a safe environment. They want minimally intrusive environments. They want a good internet connection. So we have to be careful to think about what people with autism want as well. The internet and adults is another complicated story. The good news is it's very much easier to relate to the internet. It's 24/7 and out there. It minimizes a lot of social interaction. And the bad news is it's 24/7. There are significant safety issues. There's a lot of inaccurate information, and there's some real black holes that kids can get sucked into. Kids can look for things, not only kids, but adults can, if they get anxious about something, they hear about some terrorist attack, well, they read about bombs and on the internet, and the next thing you know, somebody's knocking on the door, finding out what's up with them and the bombs. So things can happen, and sometimes people will get radicalized because they're just living 24/7 in these dark places on the web. Cyberbullying, I should point out, can also be a problem, especially in adults. Cyberbullying is the one that's probably the least well dealt with in the law across the 50 states. All 50 states now have laws against bullying. Cyberbullying is a problem in terms of how it's defined, and it's a bit of a mess, but it can be a major problem. And of course, you have no idea who you're really talking to online, the person who may have this lovely AI-produced persona, and it may be somebody who's quite different in reality. The core social problem in autism, we still don't have great drug treatments for. We have some things that may be promising that are out there, some of these things that are based with oxytocin. We're still looking to see how well these work. Let me say a little bit in my last five or 6 minutes about some of the challenges for our care models. We have very limited work on models of care for adults, little treatment research, little social policy research, and we need to come up with new ways of providing these models. So what are some of the things we can think about? Well, we can look into services like voc rehab and occupational therapy supports, day programs, residential and individual therapies, residential programs, and the various kinds of individual treatments. We know that issues are challenging. If you're in the rural area, it's really hard to get a lot of supports. There's a lot of issues in terms of state specifics, the lack of flexibility, and the need to have family involvement, etc. We're trying to put together an online course on adults with autism, and these are some of the things we're hoping to cover. But you can see there's a lot of challenges out there when you think about some of the issues that we would like to cover in a course on adults with autism. And this is just a partial list. We know from the first studies that drug treatments can be effective. On the other hand, and we have some good work with adults, which is good, and it's grown and grown and grown, and we have more and more studies, but we have a lot of state-to-state variability. This shows you psychotropic drug use based on Medicaid data, and you can see a rate of 70% in Virginia and 52% in Minnesota. It's all over the place. And so we need to understand more about what makes for these differences. One of the things we know is polypharmacy is pretty common. Polypharmacy is the person complains of anxiety, you give them an anxiety medication. They complain of depression, you give them a depression medicine. They complain of being a little obsessive, you think, well, can I medicate that? The next thing you know, they're on multiple medications. My personal best on this is a person I saw with 12 different medications, 12 different behavior modifying medications, and they were a mess. And so you had to detox them off all of it to get a sense of what the baseline was before you started fresh. So we need more thoughtful approaches that are data-based. And the good news is often places that are quality places will have data. But it also speaks to the need for training prescribers for work with the ASD population. This is true both in mental health and the physical health arena. In the mental health arena, we need new models. I think in particular, we need to think about new approaches to looking at how we can best deliver care. We know what some of the problems are, so we know how we could target training and intervention. We need better work on assessment in adults. We need to understand the state variations and the diversity of outcome. The training we need includes general practitioners and internists. Nurse practitioners may be especially a good target for training because we could have nurse practitioners who get both some of the medical and some of the mental health training, could be real specialists in this area of adults with autism. And this would be a really valuable contribution, and one that would require not a great modification of models to come up with. We don't have to have new licensing systems. Child psychiatrists are all trained as adult psychiatrists. They can deal with adults and often have some experience with autism. General or adult psychiatrists may have very limited experience. Neurologists, again, it's quite variable. So again, the hope is that we could think about having some new models of care, perhaps teams of nurse practitioners, social workers, psychologists working as part of a group who could provide a more comprehensive and a more rational program of care for adults as they become older. Training is really an important issue. One of the things I discovered in my work over the years, my decades of work over the years in dealing with child psychiatry trainees, is I would tell them on the first day I met with them, I want you to, first of all, you'll be in a situation where there'll be a lot of data. Always look at the data. If you make a change in the medication, look at the data, see what happens in terms of the data. But also be aware that even a small change, for good or ill, can really make a big quality of life difference for the person. Having a small change where a person all of a sudden can go out more in public, can go out more to the gym, can go out more to shop, can go out more to be involved, that's a big change for the person, even though it's a small change in the medication. And finally, here we are at the end. This is the Let 1,000 Flowers Bloom approach. We're going to have a second for a little time for discussion shortly. And I'm going to put the references up just quickly so you know they're there. These are all going to be online with this talk. And I really appreciate your joining us today. And now let me get off. So I flipped through all of this. And I got it. I'm being videoed. Let's have some time for questions and discussion. And you can see my lovely background from the Teeth Farm just down the street from us on Martha's Vineyard. Okay. Stop screen. Here we are.
Fred, we've had one question come in.
Okay.
And the person apologizes first because they were late. So if this was answered, whoops. Oh, sorry, never mind. Yes, the slides will be available online later next week. The question was about the slides. Sorry. If you have a question, please place it in the chat.
And I should point out, by the way, last month, unfortunately, I was in the middle of the monsoon, trapped on my way to LaGuardia Airport. But we had a great talk on some of the new approaches, not new, some of the approaches used in some of the Scandinavian countries for adults. And if you want to look at this talk, that talk is also going to be online if it's not already. And that was another great talk. And we're going to have another talk next month, I think on the 17th of November, on biomarkers in autism. So we have a great talk series coming up. We've had a set of very good presenters. Eric, who I think is maybe online right now, gave the talk last time and did a Fulbright based in Norway, but looked at people in the Scandinavian countries and looked at some of the models for adult care, which it was a very interesting, it's similar, but also different from the US. Any questions, comments? I should point out, by the way, one of my references, if you want to read one paper that's relevant to this topic, there's a very good paper. It's called something like Minding the Funding Gap. It's a pun around the British minding the gap on the tube station. But it points out that I believe there are exactly 4 federally funded grants on adults healthcare at the moment in the United States. 4. Which speaks to the problem. There's a lot of money going into young children with autism. There's very little money going into adults with autism, and that's really a shame, because that's a population that we really need to think about doing more in terms of supporting.
Sorry, I don't have the ability to type, but I wanted to ask Dr. Volkman, first of all, great summary lecture. From a parent's perspective, what are the things that you found with your cohorts over the years that are the most helpful for promoting executive function?
Good question. Interestingly enough, there have been some attempts to come up with, starting in childhood, but continuing through adolescence and into adulthood, some computer-based games, strategies, teaching things that teach executive function skills. And so, and a lot of these are very fast-paced visual games. So there are some things that you can use that are online. And the great thing there is the person can, do them on their own time, and they're engaging. There's a whole series of books, I think, called Smart But Scattered. And this becomes an issue, of course, also for adults with ADHD, who sometimes also have executive function difficulties. So there are some supports out there, and there are some very specific and explicit teaching strategies, as well as some of these computer-based games that can really be very effectively used. And the important thing is to start where the person's at. So you really need an assessment to kind of know what level is the person's executive function at. And there are some very quick psychological tests that can kind of get you there. And then starting there, really try to intervene, starting with where they're at, and build up that ability to multitask. It's a hard one, but even, for example, with driving, there are simulated driving programs now that can be very helpful to people. And again, driving is an interesting one, because when you think about it, driving is very social. You have to pay attention to the other drivers. You have to pay attention to the road conditions. You have to make accommodations. You have to do all this stuff. And simultaneously, you're paying attention to how fast you're going, where your foot's on the brake or on the accelerator. If you've got the windshield wipers on, it goes boom, 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 boom. Well, there are programs and there are simulators that you can, find at different places. So there are approaches, and there are special needs driving instructors who will work with people about just these kinds of issues. So it's a matter of really connecting with the resources. That's, again, is one of the challenges in this whole area, is somebody like me, I see a lot of resources, but how do you help people connect to them? And, you go to the internet, and that's not very helpful, because you get 150 million hits. You have to start being very, very specific on the internet. Computer games, executive functioning, autism will do better than just executive functioning. So that there are things out there. I can't say that they're all necessarily well evaluated, although some are. And there are more and more apps, again, that are out there. Only a few studies of the apps and how well they work. But I think there's something now like over 1,000 apps that claim to have some benefit in autism, and some of these focus on executive function.
Just the notion that executive function equals multitasking is very useful to me. I've never heard that summary before, but it seems to me like it's right on target. So thank you for that.
You're welcome, although my psychology colleagues would probably tell me it's dumbheaded, because it's many things more, but that's the kind of core of it, to my mind, is being able to do multiple things at once and pay attention. And I think it's fundamentally and deeply a social task. And one of the reasons why it's so much off in autism is because when babies are growing up, they're not paying attention to a lot of different things and trying to make sense out of the world. They're over-focused on one or two things. And so it's that ability to kind of let your focus wander a bit that's so interesting and such a challenge to people with autism.
Fred, we do have a question that came in from Eric Benninghoff. for last one. He's wondering, he said, we both discussed the idea that having a job is a major determinant of life satisfaction. What do you think are some effective methods to educate and support employers in taking this population on?
Oh, very good question. People have used a range of approaches. I was visiting last spring, I suppose it was, a residential program in New York, a lovely program. It's kind of out in the boonies on a farm, but as you get to it, you go through a little kind of section of a town. Well, this section of a town, it turns out this organization owns a fair number of the buildings. And as part of the condition of leasing the buildings to businesses, the businesses have to agree to take 1 or 2 students on as workers. So that's one model. And that kind of model at its most basic level sort of requires people to really think about hiring, to build incentives for people, either through taxes or other kinds of things. And again, I have to emphasize very much, I'm not a lawyer, I ain't a tax man, but to think about ways to encourage businesses to do this. People with autism can be great employees. My experience is having had multiple people with autism as my employees over the years. They're very faithful, a foot and a half of snow comes, they make it through the snow to come to work. My child psychiatry trainees can't walk a block because the snow is pretty deep. But it's very interesting that we need to emphasize the strengths. And then we also need, as we think about what the areas of challenge are going to be, to think about, well, where are you going to put people with autism, and what are they going to be doing, and to what extent do they have social interaction requirements, and how intensive are those requirements? Also, I think, in my experience, many of the places that do the best job are places where there's a parent somewhere in the system. So there's a parent who is actively thinking about the needs of a person with ASD because they have a child. And so they want to encourage other people to think about that in their organization. And that often works well. And you have some very forward-thinking companies who will, look at that. Some of also with computer companies, it's one of the areas where people with autism can really excel at times. Computers, things that have to do with computers. So thinking about a good fit for people, the good fit is really important. I haven't told this audience today. I worked with a man some years ago who was a lawyer who got through a very good law school. I won't say which one. And he wanted to be a public defender. He was really committed to wanting to work with the public. And so he was a man with Asperger's, and he would go visit the man in jail, and the man was alleged to have held up the 7-Eleven. And so this lawyer would say to the man, well, did you do this? And the guy would say, yeah, I did it. And then the lawyer would say, well, you got to plead guilty. And the guy says, no, you don't understand. Your job is to get me off, not to get me guilty. And that's a problem. Because you can see from the one side, the lawyer's job is to help the client. And that's what comes first. So it's a problem when at the same time you have somebody who's really going to be committed to telling the truth. So we worked for a long time and finally found him a job in patent law, which was a much better place for him because you don't have that same issue of the personal aspect. It's really much more cut and dried, and you can get to the minutia, and it was a good fit. But it's funny things like that. I had one man, I had this great idea that I was going to help him. This was in the old days. He had 2 college degrees, a master's as well as a bachelor's degree, and he couldn't find a job. And we pulled some strings and got him a job keeping the card catalog at the medical school library at Yale. I don't know how many people remember the card catalog, but there used to be existing these things that had index cards that were on little boxes, and you could look up the author's last name, you could look up the title, or you could look up the subject. And there was a whole wall of card catalog to find these books. And people would come along, and people in the library said, this guy was the best person ever to keep the card catalog. It was the best it had ever been. He was such a good worker. He got fired in 2 weeks. And the reason he got fired is folks would come and they would bring their little pieces of paper and stick in the card catalog to show what they needed to come back to look at. And so he would come to pull these out. and he would get into altercations with people, and he would yell, and by yell, I mean wake the dead, yell, not just raise your voice. And of course, in the library, this is totally forbidden. So even though he was the best person ever, he only lasted a couple of weeks. So that, and it was one of those things that in advance, you wouldn't necessarily have anticipated, although with the wisdom of hindsight, you can say, oh, I can see how this is going to be an issue, because you think you're going to minimize social interaction, and yet there it is. People sticking little pieces of paper in the card catalog. So I think being a little cognizant of the person, but it's a very interesting problem, and we need to do more about it, because if we don't, it's really costly both for the person who does not feel so good about themselves. As you say, having a job really helps you feel much better about yourself, but also for society. Having a person in residential care is very costly. $250K a year, that costs a lot over a person's lifetime. So we really need to think about models that are more efficient and effective. And it's interesting that some of the places I've seen more recently, people are going back to these kind of farm-based models where there are good modifications for what has started off well over a century and a half ago. The origins of what became the state training schools often was these farming communities for people with disabilities of various kinds, which then turned into not such great places, but people are kind of going back to that as ways that they can have some mastery of the environment where things are not too intrusive and people can feel good about doing things. But we need to think also about making modifications that are rational in terms of some of the state requirements. Some of the state requirements are very good and sensible. Some perhaps should be modified looking at the context, and it should be more flexible. So it's an interesting problem. And I think, again, if we were to look from state to state, we'd see a lot of variations. Any other questions, comments?
That seems to be it for our questions today.
Right. So thanks everyone very much for coming. Next month, which is very shortly upon us, we are going to be having a talk on biomarkers in autism. You're all welcome to attend. Thank you very much for coming. If you're interested in this course on adults with autism, which is I think going to be an online continuing ed course, let me know. I'm going to try to get that organized hopefully for the spring, and it will be off the usual Southern schedule. So let me know if you have an interest, and thanks for attending.